Right, so it is my very great pleasure to introduce Professor Cristina McKean from University of Newcastle, but soon to move to University of Oxford. And your grant had a very long title, Testing the Efficacy of Building Early Sentences Therapy, acronym BEST, which I love, and Uncovering Mechanisms for Change, a theoretically informed language intervention for preschool children with language disorder. And the title of your talk is far too long for me to read out. You've got it there. But this is a cluster randomized control trial, which we love. So take it away.
Thank you very much indeed and it's fantastic to be here and to listen to these talks. We're moving now to think about intervention. A lot of what we've been talking about previously has been around identification, so this is a very different flavour of study. In 2019 we were really delighted, thrilled to receive the funding from the Foundation for the Lively study. We called it Lively, Language Intervention in the Early Years, and that was to have some balance when we were talking to schools about the two interventions that we were going to be using in the study. We couldn't call it Building Early Sentences Therapy because that would introduce a large amount of bias, so we created the Lively project. So yes, in this, our goal in this study was to conduct a cluster randomised controlled trial with settings. The early years settings were being randomised, not the children, to receive either Building Early Sentences Therapy, an adapted version of the Derbyshire Language Scheme, ADLS, or continuing classroom support. So there's not much of a cliffhanger here, is there, anymore, to say we started data collection in January 2020 and we got baseline data for around 120 children who we then never saw again, unfortunately. So the COVID pandemic meant that the study paused till January 2021. And when we came back to collecting the data again, we were really concerned about the ethics of conducting a continuing classroom support treatment arm in this study. We didn't want to go into schools, given the horrendous levels of need, and just test children and not offer anything other than testing, given where the children were at. So we changed our study design to compare BEST and ADLS. Those of you who do intervention research will know that head-to-head comparisons like these mean we're making it very hard for ourselves to find an effect of an intervention. And I won't tease you, but you'll find out at the end whether or not we found an effect. So usually I wait till the end to give my thanks, but given the situation with COVID, I wanted to really put it front and centre, the huge efforts that the team went to make this study possible. So I want to acknowledge the enormous professionalism, flexibility and resilience of our research associate team. They continued to deliver the intervention during the pandemic, and their commitment to providing high quality and safe intervention to the children in the study at a time when the needs were so high. We worked with the Public Health England representative in the North East region, and we went to them and said, we have this intervention study, we have this funding, is there a way we can get into schools and do this safely? And he said, absolutely, you need to do this. The need is so high, let's find a way to do it. And I have to take my hat off to Christine Jack, Emily Armstrong, Kate Conn, Jenny Sandham, Naomi Rose and Elaine Ashton, who delivered interventions with extremely detailed cleaning protocols after every group therapy and visors and all these other aspects of safety that we put in place. So thank you. You were awesome. And also the early years practitioners, parents and children, it was really humbling to see teachers who were dealing with so much in schools who still got behind us and said, yes, we need to do something for our children, and supported us to get into the classroom. So I just wanted to say that it's truly humbling to work with educators at that very difficult time. And of course to the Foundation, who were really flexible and supportive given what seemed to be a catastrophic events for an intervention study. So thank you. So why should we compare interventions then? So why don't you just do treatment as usual and another intervention? Why should we look at comparing interventions? Well, I think in terms of practice, it enables us to have informed choices to be made regarding which interventions might work best for different outcomes, for example. So maybe one intervention is better for comprehension, say, and another for production, or one for syntax and one for vocabulary. Also, so that schools have got a menu of interventions that they might be able to choose from depending on what would fit best with their context, or even family preferences as well are important. We get preferences in all of our other medical care, but we don't necessarily get it in language interventions. So the more we know, the better we can provide people with choices. The reason I wanted to do it is also because I'm a linguistics nerd, and I wanted to be able to compare interventions that came from different theoretical perspectives. By comparing interventions delivered with the same dosage, delivery, context and treatment fidelity, it allows us to test whether it's the specific learning mechanisms that we're using in the intervention that are making the change for children, or whether benefits are therapy general effects. Is it just having a lovely time with a nice, friendly therapist that makes the difference, or is it actually what we're doing in the interventions that make the difference? So now to introduce you briefly to the two interventions that were in the trial. So Building Early Sentences Therapy, or BEST, is an intervention for young children with low language abilities, aged about 3.5 plus. And it aims to develop children's ability to use a range of simple 2, 3 and 4. It's because I've got clause in my head, 4-element sentences of these subject, verb, object, subject, verb, object, and subject, verb, object, adverbial. So these simple sentence structures. And the goal is that we want them to be able to use those sentences flexibly with a range of verbs and nouns, and to do so with appropriate grammatical morphology. So in my experience working with preschool children with language disorder, I found children could often use a subject-verb construction, but they could use that with one verb, but not many verbs. Or they could do an SVO with 2 verbs, but not many verbs. So this is about children being able to do this across different constructions. We see the children 15 minutes, they're in group sessions, and it's 15 minutes for each group session. It's really short and snappy. Twice a week for 8 weeks the children are seen. And we have homework booklets that are sent home which mirror the sentence structures that happened in the session. A booklet with the same sentence structures goes home to families to ask them to provide input to their children, just to share these books and talk about the pictures. It's really simple homework. So BEST is based on usage-based or constructivist theories of language development, and these theories suggest that children's language moves over development from fixed or rote-learnt constructions towards more flexible and abstract representations. And that once a child has an abstract representation of a sentence structure, that this can accelerate children's language learning. Sorry, I'm scared I'm going to lose that. So once you've got these more abstract representation of argument structures and syntactic categories, that creates a more efficient processing mechanism which accelerates future language learning. The drivers of this change are the input, so the nature of the input the child hears, in terms not just of the amount the child hears, but also its content and how the structures are distributed within the input that the child hears. And then the other driver of this are the cognitive tools which children bring to bear on the process of language learning. So our hypothesis is that by systematically manipulating the nature and quantity of the language a child hears, BEST can promote the development of abstract representations and so accelerate language learning. So, just a point to be made there, that also what we're suggesting is that the other motivator is that we hypothesize that children with language difficulties have less access to these cognitive tools that are used in typically developing children. And what we're doing is really hyper-exaggerating the nature of the input to support the children with language difficulties or at risk of language difficulties to harness those tools. So these are the cognitive tools that are leveraged in BEST. I won't go through them all, but we can talk more later maybe. So we're we're manipulating the input to try to support intention reading, bootstrapping, categorization, analogy, schematization, and then also looking at ways to support retention of new learning. So yes, with this idea of exaggerated input. So how do we manipulate the input in BEST to try to support children to leverage these tools? So the intervention exposes children to 11 sets of paired verbs. Each pair has the same predicate argument structure. And within a joint action routine, the adult models the target sentences with toys, and the child hears the input, sees the input, sorry, I'll go through it. I'll tell you. Sorry, video would be very helpful, but we haven't got it. It's very hard to explain. So we have this joint action routine with 2 phases. Phase 1 has input with variation, and what happens here is the adult acts out the actions with the toys and gives the model to the children. And phase 1 is input with variation, and they see the adult act out and say the toys, and what happens is you've got the predicate argument structure here of subject, verb, object, or agent, action, patient, and what we do is we vary one of the nouns in the slots. So we say Teddy's washing what's he washing there? A cup. Teddy's washing an orange. Teddy's washing a banana. Teddy's washing a carrot. Blah, 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 etc. So they hear that manipulation. And then they have phase 2, which is output with contrast plus variation. And here, again, the adult acts out the activity with toys, but they ask the child to tell them what's happening. And here they have a sentence structure which has the same predicate argument structure, but it's a different verb. So the idea is we're aligning these 2 sentence structures with the same predicate argument structure next to one another so that the children can use a schematization process to create an analogy that it's the same predicate argument structure across the 2. So this is output with contrast and variation. We ask the children what's happening in that activity, and whatever they say or they don't say, we give a long pregnant pause, as you can imagine, and then we recast whatever the child says to use the correct sentence structure. We don't demand children say anything, but we give them lots of opportunity to say something. Importantly, we also use sign in this intervention. So we sign the content of the sentences using Makaton, and we sign the morphology using a Paget-Gorman sign system. So the grammatical morphemes are also signed. And we rotate through the structures over the course of 16 sessions. So children don't have to master a sentence before you move on to another one. We just rotate them through so that they're getting this distributed presentation, which has been associated with greater retention of learning. Okay. So we've got preliminary evidence that building early sentences therapy is effective in improving production standard scores when it's compared to treatment as usual. In this quasi-experimental study, a pilot study led by my PhD student Anna Trebash, we found this large effect size of 1.08, which is very large. But obviously, because it's a preliminary study, we need to be a little bit cautious about that effect size. But it clearly means BEST works when compared to not doing anything at all. We also, in her PhD, she compared BEST with and without sign. And she demonstrated very clearly that BEST works without signs, but with sign, it works even better. So sign is definitely an active ingredient. So yes, BEST works in comparison to treatment as usual, and sign is an active ingredient. So now to tell you a little bit about the Derbyshire language scheme. So DLS is one of the most widely used intervention approaches in the UK, or it certainly was when Sue Ralston did a survey in 2012. I'm not sure if it still is, but it was at that time one of the most widely used interventions in the UK. For those of you who don't know, it's a syllabus and that's based on typical language development and the developmental progression that was described in the work of Bloom, Brown and Goldberg, so early typical language development. It uses structured play activities designed to be meaningful to children who are in nursery and who are encouraged to use their language to direct other children or the teacher in play-based activities. Children move through stages, increasing their understanding and use of sentences with 1, 2, and 3 and 4 information-carrying words. And the scheme includes materials to assess the children and is a flexible source of activities which enable individualised progression through the programme based on the child's progress and their initial language level. So we worked with Mark Mazidlova, who very kindly supported us to use DLS in this programme, in this research. So we also have evidence that DLS is effective. So we're comparing two interventions with evidence that they work. But for DLS, we've got evidence that it's effective in improving children's comprehension when compared to a waiting list control. And this was presented in the work by Broomfield and Dodd in 2011 in their large randomised control trial comparing to a waitlist control. And it's difficult to extract effect sizes from that paper, but you can take an estimate that it's around 0.6 Z-score change in comprehension for these children receiving DLS in clinic. The adapted DLS, which we're using in this study, is a version of DLS which can be delivered with high treatment fidelity and reliability in a research context. So we know that DLS in its usual form is incredibly varied in the way that it's used in the wild, as it were, and in fact is often just a few people playing around with information-carrying words rather than delivering the programme. So we needed to turn it into something that could be delivered with high fidelity and reliability in our study. We wanted it to match best as closely as possible in terms of dosage and the delivery context, whilst retaining the key principles of information-carrying words, play-based activities, turn-taking, use of prompts, etc. We also wanted to make sure it could be delivered in groups, and we delivered it to children at 1-word level, 2 to 3-word level, or 3 to 4-word level, depending on their starting point in the study. Again, we provided homework packs and guidance videos for parents. So again, after each session with the children, the activity was sent home, a sort of mini version of activity was sent home to parents, and they had QR codes that they could go and watch a video to see how to play the activity. So it differs from traditional DLS, as it were, in that it moves more rapidly through the range of DLS target structures. So we don't work on one structure until it's mastered. We move through a few different structures for the children. And it's slightly less individualised in terms of progression and modification of resources. We did allow children to progress through, as they do in the Derbyshire language scheme, but we didn't have as much ability to modify what the children were doing in the sessions as if you were doing an individualised intervention. There's some more details of these differences on the Lively website that you can have a look at. So here are our hypotheses then that we wanted to test in this study. So we hypothesised, given the previous research that we've done and others have done, is that BEST would be associated with larger gains in production standard scores, that we'd get better gains in production for BEST, and that DLS would be associated with larger gains in comprehension, given what we know about the approach. We also hypothesised that BEST would be associated with greater gains in standard scores in an omnibus language measure due to this hypothesis that we have that if we can get the children to have abstract representations, they can generalise their learning to other structures more readily. And also that if they are developing abstract representations, that will support them to learn language after the end of the intervention study. So we hypothesised that BEST would be associated with greater gains after the intervention due to the processing advantages which are afforded by more abstract representations. So we haven't made up these hypotheses post hoc, you'll be glad to know. These are all in a pre-registered report that we registered before we started collecting data. And that also has our methodology pre-registered as well, if you want to have a look. So our research questions then are linked to those hypotheses. We're looking at whether, first of all, are BEST and DLS associated with improvements in standard scores, expressive and language, receptive and expressive language scores, and also we wanted to look at communicative participation. So does it make a difference in the real lives of children, not just in their standard scores? We wanted to compare which intervention was more effective, and we also wanted to look at whether there was differences in the degree to which the benefits of the interventions transferred to non-targeted language structures. So do you just learn what you're taught, or do you generalise your learning to other aspects of language? And then we wanted to look at this question about post-intervention change, which is linked to our hypothesis about usage-based abstract representation, rather than in children. So now to our methods. This was a cluster randomised controlled trial with settings randomised by an independent statistician external to the study. And children were eligible if they were aged between 305 and 405 at the start, monolingual speakers of English, although we did have a subsection of our study which was about delivering intervention in home language, and we adapted BEST into Mirpuri, Polish and Sileti, and one of our posters that Elaine Ashton is presenting in the lunchroom gives some results from that piece of work. We excluded children with sensory neural hearing impairment or severe visual or learning disabilities. The children had to be able to participate in a small group, and they all scored at or below the 16th centile for production or comprehension on the new Raynell developmental language scales. As we said, the interventions were manualised and standardised set of therapy resources, and we did fidelity checks throughout the intervention study to make sure that the interventions were being delivered as intended. See, small group delivery, 16 times 15-minute sessions twice a week for 8 weeks. That's pretty low dosage when you look at the research for interventions. All the assessments were completed masked to intervention arm, so blinded or masked to intervention arm. And we tested the children at 3 time points. At the baseline, before the intervention, at time 2, at outcome directly after the intervention, and then follow-up, which was between 9 and 11 weeks after the end of the intervention. And we measured them on a standardised measure of receptive and expressive language. So we used the new Raynell developmental language scales to do that. We also tested them on the knowledge of their language structures which were included in the interventions themselves, the language that was targeted in the interventions. And for BEST, that was a picture description assessment, but using all the sentences that were targeted. And for ADLS, this was a rapid screening test, but we extended it so that it was more sensitive to change. And then we used the focus. That's the functional outcomes in children under 6. I don't know if people are familiar with that one, to look at communicative participation and changes in that across the interventions. Okay, so a total of 21 schools were randomised to receive either BEST or adapted DLS. 1 school withdrew, so we ended up with 10 schools in each arm. And a total of 102 children received the interventions, 44 in the BEST arm and 58 in the ADLS arm. So now moving to the results. My pointer doesn't work, I'm going to have to point like this at things in a moment. But so moving to our results, our first question. Oh, have you got another pointer? Amazing, thank you. That's amazing, thank you very much. So is that gonna? Yes, that's going to do its thing. Thank you. So moving to so for our first question, whether or not BEST and ADLS are associated with improvements in receptive or expressive language and communicative participation, I'm just going to show you some graphs first of all for that, and then move to a table to look at group comparisons. So first of all, just to get a sense of the sort of change, that we're looking at. So What we have on the graph here is we've always got BEST on the left and DLS on the right, and we've got baseline, outcome and follow-up in those colours there. So what you can see here is both interventions are associated with significant change over time. Here in comprehension, I'm not sure if you can see that pointer very well, here in comprehension standard scores, and here in production standard scores. I'll talk about group differences in a moment, as I say, but they're statistically significant improvements that we're seeing there. And as I say, in standard scores, which is nice rather than just raw scores. And again, we can see significant improvements in the targeted language structures. So here, this one, I am going to just point. This top left graph is BEST, the target structures in BEST, and we can see the BEST intervention has a rapid growth in what you're targeting, so they learn what you teach them, which is nice. The DLS still has growth there. BEST again with the this one at the top right is the structures targeted in DLS, and we can see growth in both there as well. And then this is looking at functional outcomes at the bottom, and again we can see significant improvement in both arms there. So now looking at which intervention is most effective and whether they differ in the degree to which benefits transfer to non-targeted language structures, and whether they differ in terms of the degree to which progress happens after intervention. So just a note to say, when we're comparing the interventions, we analyse the results adjusting for any baseline differences. So where there was any differences in children at the start of the study, we statistically adjusted for that. So first, looking at new RAINL language outcomes. First, we've found that BEST was more effective in improving comprehension development after the intervention with a large effect size. So it's a slightly unusual pattern, but when we look overall, comparing T1 to T3, there's actually no significant difference between BEST and DLS. So BEST and DLS are the same in terms of their ability to improve comprehension scores, but we've got this slightly unusual pattern in the BEST children that the gains only happen after the intervention. In terms of production, building early sentences therapy brings about greater change than DLS between T1 and T2 and T2 and T3. And again, we've got this really significant improvement happening at the end of the intervention, post-intervention in children's production scores. And these are moderate to high effect sizes that we're seeing for production there. When we look at the targeted structures in the interventions, we find that BEST is better at improving BEST targeted sentences, which you would expect between T1 and T2 and overall between T1 and T3, but there's no significant differences in the DLS structures. So BEST and DLS improve those structures similarly. When we look at communicative participation, we find no significant differences between the interventions. The Focus 34 doesn't generate norms, but it enables the evaluation of change over time and the identification of something that the authors called significant and clinically important differences. So they've validated a way of deciding whether or not what's happened in an intervention is bringing about a meaningful change to a child's communicative abilities and participation. And that's a score of greater than 16 is seen as a significant clinical change. And overall, 66% of children across the whole study made this significant clinical change. And that was 73% in the BEST arm and 61% in the ADLS arm. So this was an average difference of 33 across both interventions, which felt like a really important finding, particularly given the tiny dosage in comparison to other studies. So they're both associated with clinically important improvements in communicative participation. So to conclude then, perfect, I'll just tap dance for the last 3 minutes. So to conclude, we find clinically significant improvements in communicative participation from both interventions with relatively low dosage. We do need to exercise some caution because we don't have our treatment as usual arm to compare against. So potentially there could be some sort of regression to the mean happening here. So we do need to be cautious about that. But given this methodology of looking for clinically important significantly clinical important differences within the focus, we do feel confident that this is real, as it were, in these children. I believe that creating change in non-targeted structures is vital for effective and efficient interventions. If the children only learn the things you teach them and they don't go on to then change their language learning abilities outside of that intervention, then it's a highly inefficient intervention, and it's very difficult to feel that the children are going to improve. And unfortunately, that is the case for some interventions. They only learn what you teach them. So if we can make this happen, I think we are creating much more efficient interventions. And so we're really excited by the findings about BEST. So BEST promotes greater generalisation beyond targeted structures than the ADLS with, I think we've got the wrong slides here. Yes, we've got the wrong slides here, apologies. It's not greater gains for comprehension, it's the same gains for comprehension and greater gains for expression in the NeurANL developmental language scores. And BEST is associated with faster progress after the end of therapy for comprehension and production standard scores. And we think that this supports our hypothesis that BEST promotes the creation of abstract representations, which then can accelerate future learning. Thank you.